to like come here without an app.
Yep.
So this is one of those things I hope we get to talk about a little bit because typically when you hear of an EGFR mutation, you don't hear that in the PD-L1. So we'll circle back to that as we're talking tonight.
Hi, my name is Rick Meyer. I was first diagnosed in November of 14, so I'm coming up on my 5 years. That's pretty exciting. I am ALK positive. And started with just the lungs, lymph nodes above the clavicle, so I guess I was stage 4. They were kind of debating the 3B or 4. I think that was more about trial opportunities than anything else. Anyway, I've been on crizotinib for about 19 months. Got progression to the brain. Switched over to X396. Loved that drug. I was on it for 2.5 years, and it was like taking baby aspirin. I mean, 0 side effects. We're talking great quality of life.
There you go.
But brain progression continued. Went to alectinib, was on that for about 6 months, and could never balance the side effects. It was horrible for me. A lot of people do great on alectinib, but I got to the point, if I was on full dose, I couldn't walk. So that was unacceptable. Now I'm on brigatinib, which I'm tolerating fine, but don't know how it's working. I'll find out next week when I go in for my scans. My biggest challenge is all of the drugs have worked perfectly in the body, but the brain progression continues. And we've tried blood biopsies, we've tried even a spinal tap to get, cells that way. And, the good news is you don't have all this stuff floating around your system. The bad news is you can't get what the stuff is. So it's more like picking drugs based on side effects or, what might work, but you can't necessarily get the right drug because you don't know what you're dealing with. So that's my challenge. But like I say, almost 5 years, feeling great, loving life. And this is my wife, and she's awesome.
That's the best thing you said. And everybody should always remember there are no two patients alike. Right. So I mean, it's great that you're all in here hearing each other's stories, but what's working for one isn't necessarily going to work for another. So, that's why we have, lovely people like Karen to figure that out. You're all unique. You're all very, very unique.
Hi, I'm Rick Bryson. I was diagnosed with stage 4 adenocarcinoma in February of 2015. I have none of the genetic mutations, so I got to go on traditional chemo. Started with carboplatin Alimta and then Alimta as maintenance. I had progression in my adrenal gland, and since it was the only active tumor, they were able to surgically remove it. Then I was on Taxotere for a couple of months, and in February, a year later, I had my first clean scan, and 2 weeks ago I had a continuing clean scan, so it's been 3.5 years that I've been NED, no evidence of disease. I did have, I was able to find the Addario Foundation back through the Stanford Lung Cancer Support Group, and have found it to be so beneficial and helpful and informative on becoming a better advocate for myself and knowing what questions to ask. So, thanks.
Great.
Thanks, Rick. I just want to point out something that you said, because I think it's really important, and I know a lot of you in the room have referred people to this support group and other support groups within the Bay Area and those online to this support group, and then other support groups in your neighborhood. But don't forget to tell people that we're here. If you think you benefit from it, other people will too. So don't forget to mention it next time you are passing a
And this is the
a
only
friend
one.
in the
Yeah,
space,
this
yeah.
is the only one I know of, and of course you always get support here for sure. I mean, that's a given. But this is an educational evening as well. So you all leave loaded to go back and have a conversation with your oncologist or your surgeon or whomever you're dealing with at the time. Ready to have a really good two-way conversation
Yeah.
with your physician.
Sure.
Ina,
I know.
what have
Hi.
you been doing?
I'm Ina Bauman, and I'm so glad to be here. And everything that you said about what the living room is, but there's one more thing, and I haven't been here for 3 months, and I'll tell you why in a minute, but I was so happy to come tonight. I was like so thrilled to see everyone and meet some new people, but you really make a lot of friends here. And the connection is so amazing. So even if you're not lifelong friends, you kind of feel like you are.
Right.
So that's a
Exactly.
really important part of what
Yeah.
this group does. So
Yeah.
thank you for that. Back in April, actually, the day after our April meeting, and we had our early detection meeting before the meeting, the day after, I found out that I had a new cancer. I was diagnosed for December of 2014, end of December 29th, so practically 2015. And I thought, oh my God, I'm coming up on my five years. I had a total left upper lobe and partial lower left lobe lobectomy. So I was super lucky. It was an accidental finding, and they were able to just take the tumor out. And so I didn't need any medication. And I was, as I said, sailing along. And then the day after our April meeting, I had a previous scan for my routine checkup. And they said, oh, yeah, it looks like you've got a new cancer in your right lower lobe. Not a metastasis, but a new cancer. So anyway, we got everything into high gear, and I was able to have stereotactic radiation. I share a wonderful radiation oncologist who we're going to try to get him here, because I think everybody would benefit from knowing Dr. Dan Schiffner in Palo Alto, Panth.
Perfect.
And I just found out today, I have to wait 3 months for everything to have an initial scan. And I had my scan yesterday morning, and my results were back today. And apparently the stereotactic radiation it's working, it's doing its job, and the tumor's shrinking, and there's no new growth, and there's no new tumor. So, I just found that out today. So I'm pretty excited. And I think there's some people that are online who I haven't had time to tell. And I'm sorry. I was with my grandkids all day. I couldn't share the news with anybody. So thank you.
So they're at home clapping too. Yes.
Great.
Your
did tell
phone's
some-
probably blowing up with your text messages right now.
Exactly.
Tina's crying.
Yeah.
Nice work.
I'm almost crying. My name is Tina, and I don't think I've ever shared my very beginning with you before, but my first symptom was a tiny little knot in my neck, and I thought, this is like something weird, and I was going to Hawaii the next week, and so I thought I needed to get it checked out, and she goes, I don't really like that very much. Let's do a chest x-ray. Like within 20 minutes, she says, oh, you have a mass in your lung. So that was the beginning, but things moved really fast for me, and because this was in this place, they could surgically get to the cancer, because they said, yeah, there's cancer in that lymph node, and they could do the biopsy right away. And so the first thing they did, and this was in 2010, they did test it for EGFR, but I don't think they tested for anything else, because I came up
That's about
positive
all
for
they would test.
EGFR.
Yeah.
So I thought, okay, I'll take it. So anyway, that was my beginning, and it went really fast. And I started on Tarceva at stage 3B, and then once I got to the third doctor, I just didn't feel like that was aggressive enough. Taking a pill, that's too easy. So the third doctor at Stanford said, you really could maybe beat this thing if you did standard treatment, radiation and chemo. And I said, give it to me, I'm ready. So I did do that, and then after, I had a clean scan after treatment, and then he said, let's just, go back to the Tarceva. We know it works for you. Let's just go back to it, and, little insurance for a year. Let's do it a year. Well, that year's turned into 8 years, and I'm still taking Tarceva, and I'm still getting clean scans. So something's working.
And that was novel treatment for
Yeah.
that
Yeah.
area.
Yeah.
That's
That was a
amazing.
forward-thinking doc. Yeah.
Yeah.
One thing I'd like to say about the fact that she was actually tested for biomarker
Okay, I'm
is
going
that
to point.
this was at Kaiser
Is it Tony?
almost 9 years ago, and this doctor was right away said, "Oh, they got this drug. If you're positive for EGFR, you can take this drug and it'll take care of your cancer." And after listening to all the things I've heard here, that was pretty amazing at that point in time.
Absolutely.
It absolutely was. So,
Absolutely.
anyway, I mentioned to one of the cute girls over there against the wall that I'm going on, I think, my 8th year of coming here.
Yeah.
At least 8.
Yeah. Yeah.
And we probably make it here 10 times a year
Yeah. At least.
when we're not traveling somewhere.
Right.
Yeah.
Exactly.
So anyway, the foundation has been a great for my wife and me, and I'll be here as long as I can be here.
So Rick, thank you for that. That's awesome. But I'm curious about your sunburn. You have kind of a reverse golfer thing going on there. You have burnt feet and then a white leg. I don't understand. Were you wearing pedal pushers while you were golfing?
My shorts are a lot longer than they are.
Thanks, Rick. Bridget, you have that back.
No, they've got one.
Oh, Michelle's got it, yeah.
Okay. Do not talk.
This is my wife, Joanne. She doesn't want to talk, apparently. I can't shut her up at home. My name's Robert. I was diagnosed with stage 4 in May of 2014. And my goal today was to come and show people that, there's hope. It's not going to be 5 months or 4 months, 6 months. It's over 5 for me, but heck, it seems like I'm kind of like, there's a whole group here, 5, 6, 10.
The thing metastasized to its bones. Just
So-
didn't have lung cancer. Yeah.
I almost feel like a short timer. But I've done I can't remember all the treatments and dates and stuff, but I've done chemo, radiation, a lot of CyberKnife. Most of mine in my pelvic area, bone and muscle mass. But I have had a couple of treatments that I've not had too many people mention in case anyone's interested. One is cryogenic ablation, and the other one was microwave ablation. And so if anybody's looking at that or hasn't done it and going to, I can give you some information on it. That's it.
Thanks, Robert.
Carrie.
And I know your wife is here to correct you if you make a mistake. She did talk if you were wrong,
That's what we do.
which is my husband very
Yeah.
familiar with. Right.
Yes.
First walk, the doctor gave them, we just measure it.
Yeah.
Yep.
And now he's still here.
Yep.
First
That's
walk
awesome.
after chemo, and I was
Yeah.
I was literally the last one across the finish line.
But you crossed it. Yeah.
But we did make it with a lot of help from my friends.
That's it.
That's awesome.
I have to pull this forward. I can't see this.
Hi, my name is Terry, and I just met Robert, and like all of you here, your stories really help. Not only is it because you all understand, but the way that you talk about your metastasis so calmly, because when we get news that it's spread, it's really hard. But to listen to you all share your stories about how well you're doing, even though it's come back or it's metastasized elsewhere, it's really an inspiration, and his story is really incredible.
Yeah.
So I was diagnosed on July 2017, met exon 14 with amplification. I had a 16-centimeter mass in my right lung. They put me on crizotinib, so it was stage 4, and the crizotinib worked miraculously, very quickly. I went from coughing and not stopping
Great.
with no energy and feeling really sick to back to normal within, it seemed like days. And so it shrunk the tumor by 60% in 3 months. I'd never had chemo or any other thing but crizotinib. And then it kept working. And then I had a full right lung pneumonectomy. So I'm sorry, it was adenocarcinoma, non-small cell lung cancer. And I also, there was an article written, so I had a complete pathologic response.
wow.
So that was great. But just, so that was, my operation was April 9th, 2018, last year. And then I just had a PET CT scan last week, and it did show some tumor growth in the chest wall, where, I guess, close to where the tumor was, or mass was. And so I just learned that last week. But hearing your stories helps a lot because there's hope. And they think they might do radiation, but I want to go back onto crizotinib. And I was told by some patient advocates that were here, actually, that if I stopped, it would come back. And I had mentioned that to my doctor, and he said every case is different. And, you know, it was a tough call, I guess, because I had a pathologic complete response. So we think it did come back, and so we'll see what we do from here. But I do want to go back onto the crizotinib, and hopefully it'll still work. So thank you.
My name is Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013, and I was on immunotherapy up to last September. I've been off of all treatments since, and everything's stable. I'm also involved in a clinical trial to test blood biopsies in terms of predisposition for certain mutations. In other words, you give them a sample of a tumor, and then they do about 13 different tests on a blood sample to see if any of those genes are showing up in that sample. It's still in the clinical trial stage, but it's obviously something I'd be very interested in. So, it's good to see Dave back here again. Yeah, good to see you, Dave.
Thanks, Fred.
Hi, my name is Tony Rodriguez. This is my husband, my caregiver. I was diagnosed with non-small cell lung cancer in September of 2016 after coughing up blood one Sunday afternoon. I went in, they said, my doctor said, let's take an x-ray, and then they showed a mass, and I went to see a pulmonologist, and he was like, oh, it's probably nothing, but obviously it turned out to be something. They did testing, but at the time I tested, I didn't test for any mutation. The test, later I find out that the test had a 25% false negative. And so I went on, at that time I went on carboplatin, Alimta, Avastin, and I did that for most of 2017. We had some regression, and then I went on Avastin and Alimta for maintenance. And then in 2018, I was on Optivo, and I can recall just earlier this year, I talked to Michelle here from the foundation, and later I find out I'm ALK positive, and so she says to me, well, you know, that Optivo doesn't work on ALK positive. I'm like, no, duh. It did not work. So like 2018, I was on nothing at all, and so I've had progression, and so I go on doxycycline, I believe, at the end of 2018, and my doctor, I guess he feels I'm at Kaiser in San Leandro, feels that I'm getting to the end of what he can offer me, and so he does another biopsy, and we send it out for more extensive testing, and it found out I'm ALK positive.
Hello.
Yay. Hello.
Comprehensive biomarker.
Yes, which is very important. And now, because it's like I didn't have to take chemo. I didn't have to, and I have neuropathy in my feet. My husband's really pissed. You did not have to go through all that if they had done the right testing to begin with. So that's why I came tonight, because it's really important getting comprehensive testing. And so I go on alictinib. I started on it in January of this year, and by the end of February, my ALT and my AST and my bilirubin was through the roof. I mean, 1,800, 2,400, and I almost had liver failure off of alectinib. So I get off of alectinib, and it takes me 3 months for my liver to recover. And so I just started on brigatinib a week ago. So we hope that it's going to be okay. And I've also heard that perhaps because I was on Optivo, it could have been the Optivo in my system that caused me to have such a severe reaction to the alectinib. We'll find out if that's the case. But, you know, I'm still here. I'm still kicking. And one of the things I found, the Bonnie Adario Foundation early on, and that's when I was like, I'm not going to let this take me out. You are a true inspiration to me. And so then I got caught up in my cancer, and I didn't really check in. I didn't watch the living room or anything. And then while I was flat out on my back with almost liver failure, I got back on the site, and I found the ALK positive support group. And that's how I met Rick. We just came back from the ALK Positive Summit in Atlanta. And I just want to thank you for just the information that you provide. It has been a lifesaver. And that group has been, they're better than my oncologists, because we're like, what happened to you? What's going on? I was on this. Did you have this side effect? What's going on? So it's just really been empowering and really great information. So I thank you, because you're the reason why I said, people tell you don't Google it, you know, but of course I Googled it, and it was like, you have 8 to 10 months to live. You have 18 months. But I was like, no, I'm going to be like Bonnie, who's here, and I don't care what you in Google say. So I thank you, and I thank all the people who do the work that you do. It really is making a difference in people's lives.
Well, it takes a team. I don't do this by myself. But I want to thank you, because the message you just gave to people in like 140 countries, because that's who we reach with this living room live stream. You know, it is so important to be on the right drug at the right time, because you said that the drugs were making you sick. But it wasn't. It was your cancer was progressing because you were on the wrong drug. Okay? So that message is so important to share, because you have to be educated. You know, like I said, we call this a support group, but it's really an educational group as well. You have to know as much, if not more, than your physician.
Yeah, and it was the wrong drug for you based on tolerance, what it sounds like, right? But I think one of the other things I want to point out, and then I want to move on because I want to get to the education part.
We have to get to the smart person.
But I think it's that you brought up the ALK positives, and I know a lot of these groups these subgroups are kind of coming together and really learning from one another how not only to live with their disease, but how to work within some of the side effects and some sort of tips that only somebody really going through it can know, right? So I think it's really great to
Amy was at the ALK meeting.
Yeah.
She's our very smart person in the foundation, and we're actually doing research with the patient groups, so just for their markers. So it's awesome.
Hi, you're behind a camera.
Oh, hi. How are you? I'm Shannon Isaacson. I'm actually a nurse. I've been in oncology for 10 years. I actually live in Montana, and a good friend of mine introduced me to this group to take some knowledge back to the rural areas of Montana, because we don't learn a lot. And so I'm just here for continuing education to hear what goes on in a different part of our world. So thank you.
Have them dial in.
Oh, yeah.
Any education materials we can provide you for patients, we're happy
Free.
to send
Out the door.
free.
Yeah, that would be great.
Yeah.
I've worked in several oncology units in Montana, so
Okay.
Yeah.
continuing to educate and bring knowledge back. So
That's awesome.
Thank you.
Thank you for coming.
Hi, my name's Amy, and I'm here as a patient advocate, and I brought Shannon. So,
Awesome. Thanks, Amy.
Welcome. We can't get enough advocates. There.
She's giving the microphone to me again. So for us, it's been kind of a difficult year this past year. About a year ago, my mother-in-law got diagnosed with lung cancer, non-small cell lung cancer, and she is on kind of traditional chemotherapy right now. And it's kind of the three agents, and I forget what the names are, which from that she's down to about 2 right now. Of course, unfortunately, my wife Amita, who's here with me, about 6 months or 8 months ago, she got also diagnosed with lung cancer. So I guess we have 2 in the family now, and of course we're wondering whether there is any kind of genetic connections to all of this. In her case, she was ALK positive, and the story is exactly the same as yours. She took alectinib, was on it for about a month, and then had very similar adverse reactions to it. Had to go through a blood transfusion, liver issues, and now she's on brigatinib, and she's been on it for about since March. And so far so good. Everything seems to be going pretty well, and we're just kind of keeping our fingers crossed. We kind of come here for getting education. One other thing, I guess, the old adage about doctors make the worst patients, it's true. The one thing I think we are very grateful for about being in this area, one is hearing the stories from all of you, and also the amazing care that we have. She gets her care at UCSF, her mother gets her care at Sutter, but we are able to go to Stanford as an example to get second opinions. We're also lucky enough that we know some people up at UC Davis where we get a third set of opinions. So it's great to be here, and thank you for all the work that you folks are doing.
Thank you. Thank you.
Hi, I'm Jason Rand, and this is my second living room series. The last one I came to was in April, so it's been a minute or two. I'm not a patient, but my mom was diagnosed in November of 2016, and she passed away in May of 2018. And as a result, I wanted to do something positive after losing her. And so I've run a number of marathons before, and so I decided that I wanted to fundraise and get an entry for the New York Marathon. So when I came in April, I had fundraised, I think, $0, and as of today, I've raised about $7,500. It's been really great to be able to share my story with friends and family, and honor my mom in a way that I think she'd be proud. She was very private about her diagnosis, and she, didn't share it with very many people. But I'm really glad that people can come here and get the help that they need. And I wish she had done that, but she wanted it not to be something that would burden the rest of us. So she was very private about it, but I'm so glad that this organization is here to help so many people. So thank you.
Hi, everyone. I just want to thank Amy and the Bonnie Dario Foundation for inviting me today. My name is Francesca, and I come here in 2 ways. This is my first time here at the living room. I come as a caregiver as well. I took care of my grandmother 25 years ago when she had lung cancer, and back in those days, in the early 90s, obviously there was no testing. And I remember, vividly being in the doctor's office with my mother and my grandmother, and the physician saying, don't even bother telling her she has anything. Just, she has multiple tumors in both lobes, in both, and throughout her lungs, and just let her go peacefully. And it was a very difficult decision to make because my mother had felt, honestly, we should try to give her chemo, but back in those days, there was really nothing. And so she lived about 6 months after, and she died not really perhaps knowing exactly what she had. She clearly knew there was something wrong. And so that kind of propelled me into medicine. And so the second way I come here tonight is I'm a medical director for a very small biotech company out of Boston. I do live here in Oakland, so I'm excited and hoping that I could come to more of these living room events in the future. And we create drugs for rare mutations across multiple tumor types, and one of them is in non-small cell lung cancer. And we have a RET fusion inhibitor, yes. And so for me, this is important because as a medical director, I focus a lot on trying to design clinical trials that help the patient. And I feel like, I collaborate with my internal colleagues and I collaborate with physicians such as Dr. Kelly and others, but I feel like I never really have a chance to collaborate or talk to patients. And so while I might not be able to talk to all of you tonight, I hope that just listening to you, that I can hear your experiences and that could help us design better studies for you, because I think sometimes that's largely ignored. So thank you again.
Thank you.
Thank you. Thank you.
My name is Katerina. I'm another caregiver. I'm here on behalf of my mom, Ivica. She was diagnosed in November 2018 with non-small cell lung cancer stage 4, low PDL-1, 5%, and no genetic mutations. When she did the Foundation 1 testing, it just came up positive for BAP or BAP and NF257, but those aren't actionable as I understand. So she did 4 rounds of carboplatin, Alimta, and Keytruda, and then maintenance on Alimta and Keytruda, and she had a couple stable scans and then some slight progression. So she switched to a clinical trial. She's at Stanford, beginning of July with Nectar. So it's Opvito and then their drug. She just had her 3rd infusion. She's handling it pretty well. She has like 5 days of like flu-like symptoms. So she's really achy and feels like she has the flu, and then it gets better. She'll have her first scan at the end of the month to see how it's doing. So we're praying. It's really weird to be in the seat because this is where I sat the first time 8 months ago, and I haven't been in the seat again since. So you guys are my heart, and thank you.
Okay. My name's Eric, and I am a lung cancer advocate. Was just at the National Advocacy Summit in Washington, D.C., sponsored by GoTo Foundation against lung cancer, not for lung cancer. I was there with about 300 of my friends, and we were talking to our congressman. I saw 6 congressmen and 2 senators advocating for more money for research for cancer. So that was good.
And if there's anybody in this room or on the phone that doesn't know that the Bonnie J. Addario Lung Cancer Foundation and the Lung Cancer Alliance in Washington, D.C. have merged, we have, and we now have twice, actually it's 1 + 1 = 10. We have the resources now to do even more than we were doing before. So he's talking about the summit we had in Washington, D.C. with GoTo Foundation.
I always like to joke that the 1 + 1 = 10 is really easier for Bonnie, who's chairman of the board at GoTo, and Lori Fenton, who's our CEO, to say 1 + 1 = 10, because they get to be the 101s and everybody else gets to be the 10. So
That's good. That's good.
yeah, it works for them.
That's good. Well, it's working. Whatever. Okay, I have to stop crying now. Okay.
We're still missing a few.
Yep, there we go.
Good evening. I am Ken Adler. I am a 10-year survivor post-prostatectomy, a very aggressive form of prostate cancer. I'm also a messenger of sorts. I am very fortunate to be a coach for a program known as Living Strong, Living Well, administered by Stanford. And we do some marvelous work helping cancer-challenged people to build strength, cardio conditioning, balance, and I like to say esprit de corps, to be thrivers beyond being survivors. Kimberly has the latest training schedule. We have just started our new training cycle at the various Ys. If you'd like to know more, you may talk to me, certainly, or speak with Kimberly. In my former career, I was a professional counselor, and I'm a firm believer in support groups. And I think this here and now activity is a gift, and I see how well it is received by so many of you. I wish that we had this forum, this living room activity, years ago when my now deceased wife was bravely battling her cancer. So I salute all of you for your contribution here. Thank you.
Thank you.
Pat Pritchard. Hello. Last month I told you I was scared and nervous, and I'm not good about waiting for results. And I waited for my scan results, and I got them. No change. All they could figure is that the CyberKnife treatment left a scar. So I have scar tissue. I don't have lung cancer right now. And I'm very happy. And I'll keep doing that. And I want to live strong doing Ken's program and the fundraiser coming up on the 22nd. And do what I can to help you all because I admire you.
Thank you.
Greetings, everyone. My name is Keith Crockett. It's my first visit here. I only took a few moments to see how important this group is with the fellowship and support that you're giving to each other. I'll try to give a brief synopsis of my history. The first event was in 1989 with a brain tumor, which was removed at the Mayo Clinic. It has not regrown since. And then probably 10, 12 years ago, I developed a cancer in my right thigh, big tumor. They said they removed it, and they said when it came out, it weighed over 2 pounds. So it was a pretty good size amount. And then, lose track of time, but 7 or 8 years ago, it metastasized to the lung. So I've had now three times of lung treatments, different times where we've had to treat them, where they've gone, been put aside. And now finally, one of the old spots has started to regrow, and I'm on targeted therapy now with a drug called Votrient. And 3 months ago, we started that. And now just recently, there was a follow-up CT scan, and it has shrunk significantly, probably about, by my own calculations, about 40%. So it's a significant withdrawal. And what's been important to me has been the fellowship, the support that's been around me, the church members and prayer. And I think without that, I would have never been able to survive all this. So I look forward to coming to some more meetings.
Thanks, Keith.
Thank you.
We'll go to staff after. So at this point, we've got about an hour left, which is about average for what we're going to do for the education part. But I would like to again thank Dr. Kelly for coming and talking to us tonight. As most of you know, she's from UC Davis. We've had several of our favorite docs from UC Davis come out here and speak with us. We're really happy to have her here tonight. So I would like you to introduce yourself, if you wouldn't mind.
What do you do every day?
Yeah, what are you even doing here?
Yeah, exactly. Well, first, let me say, you are all awesome and so inspirational to me. And Bonnie, of course, I can't say enough about you. I'm still trying to get the secret out of Bonnie of how she does it all. I really need to know that secret. So
It's
every time
I don't do anything anymore, really.
I still need
I
the
just get credit for everything.
All right. But I want to say I've actually been doing this for 30 years. So I started my career at the University of Colorado 30 years ago. And I want to say that even 30 years later, I'm still as passionate about what I do as I was back then. And I have a niece and nephew who I'm very close to. I have a identical twin sister. And so her children are really my children. And they are both in medicine, and they're both at the crossroads of trying to decide what they need to do. And so my advice to them is, you have to do something that you're passionate about, because you're going to be doing it a long time. And I tell them my story about how passionate I have been. And they've seen this through the 30 years, that every day I'm just as passionate. And I'm passionate because you are all on the forefront of my mind. Every day I wake up in the middle of the night many times trying to think, what else can I do? How can I leverage something else? How can I try to do maybe something a little bit off the beaten path that might still be helpful? So as I said, I started my career 30 years ago at the University of Colorado. And at that time, a young man named Paul Bunn, at that time, some of you know Paul very well, who was in charge of the Cancer Center, and he truly is an icon in the world of lung cancer. And so he was my mentor, and we went down this path to where I'll never forget, and I think I told this story in DC as well, is sitting in one of the physicians' rooms at the university writing cisplatin and etoposide, because that was the only thing there was to write, and that half the patients didn't get it. And I said, I just can't be doing this for the rest of my life. I can't be writing cisplatin and etoposide. This isn't right. And so Paul and I, again, forged forward. And I do remember the early days, because we were one of the early sites for gefitinib, the very first EGFR inhibitor. And we said, oh my gosh, really? We were saying the same thing, really? A pill? No. That's never going to work. And I also remember the days I'd given everything. For immunotherapy, I would say, oh no, this will never work. I've done it all. I gave IL-4. I've given autologous vaccines. I've done all of this, and it never worked. But it's just through technology and patients helping and giving samples that we were able now to make all this huge progress, going from one regimen, cis-etoposide, to now all of these options. It has truly been, an amazing career. That I continue on, and now is the most exciting time I could ever say, because of all the great options that we do have and all the great science. But back then it really was just about science, and today it's not just about science. It's about how you and your voice actually help us do better trials, do better treatment, take into account all of the things that you all are dealing with, the toxicity issues, that you were dealing with. I have a patient who had exactly the same thing on the alectinib, whose liver numbers went high like that too. So again, it's really about your voice. And remember, your voice has made a difference in patient-reported outcomes. Again, if you guys didn't speak up, that wouldn't have ever been important. And it is important because, again, the FDA now thinks it's important. So you have a lot of power it's good power. It's good because we work together. This has got to be us working together. And that's why we've accelerated this so much, because you all have really been the guiding force in saying this isn't good enough and we need to come together and make it better. And I so appreciated being there in July to be at the DC, and it was just so inspirational, and to tell our colleagues in the Congress that we need more, particularly in this such exciting time that we're in. And what we learned in lung cancer can also help in other cancers as well. So I just want to say thank you, thank you, thank you. And I'm always here for anybody. Anything I can do, just let me know.
Thanks, Karen. I want to.
She means that.
She does. I want to ask Michelle if anybody online wants to say hello before I give a shameless plug based on something Dr. Kelly just said. No? We have people. Lot. Okay.
We'll move right along to shameless plugs.
So I'm going to give a shameless plug because I think what Dr. Kelly just said about patient-reported outcomes is important because it is sort of this new space that people are starting to really pay attention to, where it's guiding decision-making. And Go-To Foundation has a patient registry where we are asking you these questions. So if you have not signed up, I highly encourage you to participate in the registry. There's a baseline survey. If you're on immunotherapy, there's surveys after, about immunotherapy. There's quality of life. There's surveys coming down the pike. And the docs are listening to you, and that's where they're listening. So if you haven't registered and you want to register, and you're here in the room, talk to us tonight. If you're watching online or you're watching back a recorded version, just contact us at info@gotofoundation.org, and we will make sure to get you set up. So,
and just one more thing about the registry, because when you go online and when you become a member of the registry, you can see what other people are doing that have your same markers, or you can look up the ALKs or the resistors or the ROS1ders or the KRASers, or you can look up immunotherapy. You can actually find out how your patient partners are doing and what drugs they're on and what you might want to ask your physician about.
And it's a global registry, so it's mapped out not just in the U.S., but you can see how people in other parts of the world are doing as well. So with that, I want to jump in to what we're here to talk about tonight, and that is comprehensive biomarker testing.
Good girl.
And just blah, blah, blah. And so I know a lot of you in the room bear with us because I know you've heard some of this before, but maybe somebody new watching or somebody that's going to come back and watch hasn't heard it. So I would like Dr. Kelly to talk about what is biomarker testing and who should get tested. So it's a two-part question.
So again, biomarker testing is the additional pieces of information that we get beyond just whether you have, I've heard people say adenocarcinoma, okay? So it's beyond just microscopic looking at your tumor under the microscope. We would call that kind of crude today because again, we have such better technology that we can go to this genetic level. And so biomarkers are really the genetics of your own tumor. Just like everybody in the room looks different because of genetics, your tumor is different because of genetics. And so we want to look at the genetics of your tumor, and that's why we call it a biomarker. Now, tumors, again, typically when we talk about biomarkers, we're really talking about the tumor itself, okay? And we're talking about really genes. And so that's where we call it this genetic testing. Don't confuse that though with germline testing, okay? Germline testing is what we do when we're concerned or wanting to know about genes that you inherit that cause disease, all right? That's very, very different from looking at genes in your tumors. And patients do get confused about that. A frequently asked question on when you do the comprehensive testing is, well, can somebody inherit that EGFR mutation, okay, or that ALK mutation? Should my family members get tested? And that's not the type of testing we're doing. We're only looking at tumor testing. So I hope that's very clear. That can't tell you anything about your family, can't tell you if you're at high risk for diabetes, can't do any of those things, but we can tell you the most important thing, and that is what is your tumor makeup. So that's what we're looking at when we talk about comprehensive biomarker testing.
Who are we currently testing for these biomarkers?
Yeah. So when I see a patient, the very first question that I want to know is, what you've all said. I want to know, number one, is it non-small cell lung cancer? Because that's about 4% versus small cell lung cancer, so that's just under the microscope. I want to know if it's adenocarcinoma versus squamous cell. So those are the big groups, all right? So all adenocarcinomas, or again, we also call it non-squamous, should be tested in a comprehensive manner, okay? So all the adenocarcinomas should be tested for these mutations, and you've already heard EGFR, insertion 20, MET, and ALK, but we also have BRAF. We have a very rare one that's not seen a lot in lung cancer, but NTRK. Those are now the approved biomarkers. But then we're looking for the other ones, and there's a list of RET is on that list. Also, HER2 is on that list. And there are some other newer ones that are on this list as well. So that list has become, it's a growing list. So that's why you gotta do that multiplex next generation sequencing. Now, squamous cell cancer, unfortunately, we have not been successful in squamous. Does anybody have squamous here? Anybody with a squamous cancer here? No. Okay. But squamous cell, we haven't been successful in finding these driver mutations. That's what we call them, driver mutations. We have not been successful, albeit we've looked, we continue to work on that every day. So for the squamous cell patients, the only biomarker we do is that PD-L1 testing, okay? So PD-L1 for squamous, that's all they get, okay? So on the adenocarcinoma side, we get that NGS sequencing, and we do get the PD-L1 testing too. So that would be what we would do, all right? And again, we want to know upfront what you have before you get treated. Now, again, the issues become, of course, is that if you do this tissue test, the tissue testing, it takes 3 to 4 weeks, all right? That takes time, and you're anxious and you want to get started, and we truly understand that. I do think now with the blood testing that we can get, so now we have blood tests. It's the NGS of the blood testing, and there's several companies that do that, and the turnaround time there is only like 7 days. So now there are caveats to both of those, but we're getting better at all of that. Because remember, at the end of the day, it's hard to wait. One of my most upsetting things is when I see a new patient, I have to say, yeah, you have adenocarcinoma, but we have to send it off to get tested. And it might take 3 or 4 weeks to get a result back. And that is very, very hard. So it's really uncomfortable, but you have to let you guys know what's out there. Typically what I tell patients is I say, if you can wait, it's absolutely important to wait to get these results so you don't get the wrong therapy up front, all right? I always tell patients, particularly if they're a little symptomatic, to say, remember, we got this chemotherapy backup plan if you need to go to it, but we'd rather wait to have the results. But if you really are, tomorrow, the next week, and you're just not feeling well, or you're too anxious and you're more stressed out, and you really feel you want to start the chemo, we can do that too, but we try to get the patients to wait when we know that we have a really high suspicion that you're going to have a mutation. Did you have a question?
Yeah, so just a quick thing on that subject. So I was just at the ALK conference down in Atlanta, and according to statistics down there, they're saying roughly 50% of patients, unfortunately, either because of their doctor or their location or whatever, don't even get the biomarkers.
Right.
And then with the 50% that do, the timing goes anywhere from they get test results within a couple of weeks, or sometimes it's like a 3-month process. And so if they can't work on, how do we get the world to understand that, A, you need to do 100% testing, and B, you need to get it done in a timely fashion because, we'll do a biopsy in 3 weeks because we're busy, and then we're going to send it off to whatever, and we'll get those results, and then, oh, I'm busy, I can't see you for a couple of weeks after that, and next thing you know, it's 3 months later,
Yeah.
and that's a lot of progression.
Right.
So a lot of people end up going on something like chemo or whatever in the interim because it's just not happening fast enough.
Right.
What can we do to make
Right.
that better?
Right. So
Great question.
That's a great question. So you may know that all of the societies have demanded that it's a 14-day turnaround time on the tissue to get results, okay, on the tissue. But you have to give an extra week to get the sample to the site. So we need to continue to work harder on decreasing that turnaround time on the tissue. And every company is totally aware of that and working on that. Now, the other thing is because we have the blood testing now, where you can get the results in 7 days, another thing to ask your doctor is to say, why don't we do both? Okay, why don't we do both? And see what they say. Because if you get the answer in the blood in 7 days, you have an EGFR or an ALK, you're good to go, all right? Remember, but if you don't, then you do have to wait for that biopsy result testing to see if you have anything really there. So I think the liquid biopsies are really going to help us make this faster, all right? So I think that is one thing that's very, very important. And all of the societies have really been very clear about, we have to shorten these timelines.
Yeah, we can only be as fast as technology will
we can
allow.
only be as fast.
But I think second to that, and one thing I just want to kind of reiterate to make sure everyone understands between the liquid space and the tissue space is that tissue is still sort of the gold standard.
It is the gold standard.
So what Dr. Kelly was saying is, if they do a blood test and something shows up, you can be sure it's there. But if they don't see something, you can't be sure it's not there. So you have to go back to the tissue for confirmation of whether or not.
Tissue's always the gold standard, absolutely. This is not, we always want tissue first. But again, the blood testing, I think, has really been a complement to the tissue for us. Or particularly, obviously if you don't have enough tissue, absolutely you have to do the blood test, all right? Or be rebiopsied, and we try to avoid that. So, yes, there's 2 questions.
So you said, why don't we do both? And I don't know what everyone else's experience has been, but who pays for that?
Yeah.
Because I know that, we've had liquid biopsies done twice, and both times Blue Shield did not pay. And the first time, we never got a bill from Foundation Medicine. We just didn't. And the second time, we had a doctor who said, we need to check it again, and we're going to do it, and if it doesn't get paid for, I have money, don't worry, which was amazing. But, I know everybody doesn't have that luxury, so...
Yeah. But everybody might.
Yes.
So Go-To Foundation, we have a program, and it's treatment and clinical trials navigation. And one of the services that we're able to provide as a joint organization is not only a concierge service to anyone who calls in to look for clinical trials that they would qualify for within whatever distance they are looking at, but also access to biomarker testing that we can provide with our partners for free to patients.
And the companies are good at working with you. Most of the time, patients don't get a bill, all right? You get this appeal, but you don't actually get the bill. And so it does get taken care of. That's probably what you got. So at this point in time, and again, if Medicare patients, again, are not, what I've been told is they aren't getting bills. You guys may know more about that than I do.
Well, these are all things we have to advocate for, okay? Because just to go back to the biomarker testing and why it takes so long. When you've had a biopsy or surgery and they have the tissue, The first thing that, you're in the operating room and that goes over here and they have to prepare it and they have to send it to pathology. Because what pathology does is they decide whether it's adenocarcinoma or squamous or
Right.
small cell or
Whatever, large cell.
mesothelioma or
Yeah.
whatever. So, I mean, that's one thing. That's not biomarker
Right.
testing. Sometimes people get confused.
Right.
They ask their physician, was I tested? And they go, oh, yeah, sure, you have adenocarcinoma. And no, that's not the test we're looking for.
Yeah.
Although that's important. So then the next test where the pathology lab has to actually send the tissue or the blood out and get it done. It's a process. It's a process. Can it be sped up? Absolutely. And we need to advocate for those things. We have to, bring pathology in closer to us and let them know how important it is that they move quicker.
Yes.
Because patients are waiting for that information to get on the right drug at the right time.
I know Katerina has a question, but while we're talking tissue blood, I just want to kind of put out there, is one of the reasons that maybe getting both could be potentially more beneficial, and I don't know the answer to this, due to maybe some of the heterogeneity within a tumor itself? Could that be, could there be a benefit to getting a blood biopsy along with a tissue biopsy anyway? Because maybe we don't know where we're going in the tumor.
Well, I'm not so sure about that. I think the reason to get it is really, in my opinion, is simply a time. It's simply a time. It's faster to get it. Now, again, there are caveats to all of these things, but yes, it's really, to me, I'm trying to advocate to say, I've got this patient, it's really uncomfortable because you want to treat the patient and you're waiting a month, we're waiting a month. We don't like waiting either. We're on your side. So my only reason for getting the blood is to get a result faster to you so that you can be treated. That's my sole purpose.
I only ask because, how often do we hear, the tissue was no good, it was necrotic, or you hear stories about...
that is, again, yes. So if the tissue is necrotic, it's not going to be sufficient. You absolutely have to get the blood.
Liquid, yeah.
Absolutely. And so we always have to look at the pathology report, and we've advocated for this. But remember, the IASLC, the College of American Pathologists have all said 14-day turnaround time and to make sure that their processes are more efficient. So what I do is, again, looking at that pathology report, I know there should be on the bottom, it should say, there is enough tumor tissue left to do molecular testing.
Yeah.
All right. Again, we've tried to make that standard, and our reports do say that. So I know, or I can tell, I'm pretty good at judging if there's going to be enough tissue to do the test, because that's the other thing I have to tell a patient too. So while I'm telling the patient that, e.g., it might be a month, I'm also telling them, but in a week from now, they may come back and say you have insufficient tissue. And that you don't want to tell a patient either. So my whole point is, I'm just trying to get the test results as quick as I can for the patient.
Biggest bang for
And you never have
Biggest bang for
insufficient blood.
Yeah, you never have insufficient
Because
blood.
your blood is repairing itself every day. And
No, Katerina has a question, and then Dawn will go to you next.
So I have a couple of questions. One is just to clarify about the blood/liquid biopsy, about how certain it is, because when my mom did the Garden test, it came back like 0.2% of HER2, and then the tissue showed that she didn't actually have it. And then the other two very quick small questions is, it took us a while to realize that liquid meant blood and it didn't mean fluid, because my mom had pleural effusion, so they actually used her fluid to do the foundation when testing, which we were kind of like, but wait, why didn't we do the tissue? And I won't go into the whole backstory because she didn't have enough tissue. So if you can just kind of speak to that and clarify it, because it took us a long time to understand blood versus fluid versus tissue.
Right.
And then the third thing is, I don't know if tumor mutation burden has anything to do with any of this, but that was also something that we were a little bit like, well, what does that mean? And a little bit confused. So sorry for all the questions, but.
So, no, those are great questions. So we consider pleural fluid. I can see where you'd be confused about pleural fluid, because it's a fluid and blood's a fluid, so I get it. But pleural fluid is again considered because there are cells in there that you can look at under the microscope. Maybe that's the simplest way to put it. Anything that you can look at under the microscope is kind of more of a pathology. It's pathology. So pleural fluid, spinal fluid, ascites fluid, any type of body fluid goes to pathology to be looked at under the microscope, just like tissue. Blood, they don't even see it. This testing for NGS via blood, pathology never even gets the sample, all right? It just goes to the company. You put it in a box, you draw it, you put it in a box, and it goes to the company. It never goes to pathology. Does that kind of help?
And I ask that also to help people out there, because we spend a lot of time in working with the people here understanding that.
And insufficient tissue doesn't necessarily mean you don't have a biomarker. You have to get into, you can have an entire tumor and one half of it looks completely clear and the other half looks, you can see the disease in it. If you don't hit the right spot looking for the tissue, you don't always get the information you need. And I think this is important to discuss, because when you get frustrated and you're in the doctor office and you're seeing progression and they're not sure and they keep coming back saying, we're still looking, there are reasons for that. But with the blood, it's a little bit different, but it can be the same. The section of the blood they've tested might not be the section of
Maybe
the blood
it's just not
where
shedding enough. The tumor's not shedding enough.
So no test is perfect, and each test does have its caveats, and you're pointing out some of those caveats with the blood test that didn't match the tumor tissue. But to Bonnie's point, that could be why.
Right.
Now, it used to be that Foundation Medicine or any of the other vendors as well, tissue really was tissue, and it's hard to get enough cells from the pleural fluid, but they've gotten so much better technology-wise. They can do a lot with just a tiny bit. And so now fluids, again, they spin down those cells. That makes a block. It's called a block. That's like a tissue. You cut that too, just like you cut tumor tissue, and you send that off. So, and they're really good about trying to, take little tiny bits to get these results. Now, tumor mutational burden, which is your other question that you asked, on a next generation sequencing report, they will give that to you because that's kind of a freebie. The information is already there because they've looked at all those genes. And so it's a calculation that they do. And so they just put it on the report because it's there and available. And there is some controversial clinical data about tumor mutational burden. So that's why you look at it, and if it corresponds and kind of corresponds to the PD-L1, that's great. But we don't use tumor mutational burden by itself to make any treatment decision. The only approved one for immunotherapy is, of course, that PD-L1 by IHC. Did I answer all your questions?
Yeah, that was great.
So I have a question based on TMB, and this kind of points back to when a little bit ago when we were talking about squamous.
Yeah.
Because who do we test? What are we testing for? And it's not to say that squam patients don't have any mutations ever, and they tend to have a higher tumor mutation burden, right?
Right. So squamous cell patients, so never say never. The group of squamous cell patients that we would automatically do NGS testing is any young patient, okay? Young patients, we always test by NGS sequencing, all right? And never smokers we would test because you can find EGFR, you can find these other mutations. So we always do test for those two caveats, I would say.
Okay.
Because we don't routinely test squamous cell, we don't routinely test them via next generation sequencing. You can't get that TMB, and we would never order just to get the TMB. We'd never don't ever order NGS sequencing just to get TMB. That's not done.
Got it.
Unless.
And I think it's important for you to talk a little bit about immunotherapy.
Yeah.
Because, obviously with all of these direct-to-market commercials on TV,
yes,
patients are thinking, oh my God, this is the answer. I want immunotherapy.
I want to go to IO, but before we switch gears, I want to let Don ask his question.
This is my question, but on the pericardial fluids, I had them spun down 2 years ago into a paraffin-embedded block, and Foundation was able to test it for the same mutations as if it was tissue.
Yeah.
But my question is, and there's somebody here from a company that's got a new RET drug, and now Ntrax been approved. So when is it going to be not cost effective for these community centers to do sequential sequencing when there's already an issue with not enough tissue, and with sequential sequencing, you have to use it for EGFR, ALK, ROS1, they have to use a piece of tissue for every one of those, compared to next generation sequencing where they can test for the whole 324 with one sample. So when is it going to be cost effective for these community places to just go to Foundation Medicine Garden?
Yeah, so we've already, I think, proven that it's cost effective. There was a paper that just came out by Dr. Pennell from the Cleveland Clinic who reported this. They did this mock modeling and showed that it was clearly cost effective and tissue sparing to do the comprehensive NGS sequencing. And I will tell you, in the meetings that I've been to recently with community doctors, the ones that I've been talking to really have moved to doing NGS. So
Which is next
generation sequencing. So there is momentum. In fact, I did an audience response poll on this. It's several lectures that I was giving, and the overwhelming majority. I was a little surprised to see that, but very happy to see that they've already made this move. And I think it's just a natural move for the point that you just said. More, the RET, the MET drug will be approved when we start getting these other drugs approved. The Ntrax was just approved. There's no really choice now to move to NGS sequencing. It's more cost effective. It's tissue sparing. So I think that we're getting there. And I'm hoping that the uptake is really going to continue to be high.
Yeah, and I would agree with that. I would say with some of the work that we're doing, particularly in the community setting, some of the more progressive community centers are most definitely doing what you're doing, but some of the more rural ones where large majority of lung cancer patients are being seen, sometimes quite often way more frequently than they should, or not even be offered treatment, let alone testing, which is a really, really sad state of affairs and something that we're all continuing
Some of mine, again, I always say this, it's heartbreaking to me to not do the testing. We know in the United States that testing is about 82 to 87 for EGFR. It drops to 70% for ALK, 27% for ROS1, and then we have no data on the rest of them. So that's kind of probably.
But I would be curious to even see what's happening in Montana. Like, are they doing this testing? Is it comprehensive? Is it? See.
But we need to do it because how do we know who qualifies for a clinical trial if we're not testing more patients for all of the markers?
My last slide on my talks when I talk about this is, again, I'm trying to get this slogan going. Test and treat. That's my TNT. Test and treat. That's my slogan. I don't know whether it will work, but I didn't think it was too bad. I didn't think it was too bad. It may not be perfect, but test and treat.
I've had over the last 10 years, I've had 5 comprehensive sequences done, and I get it every time I have progression because to see if anything's changed. Because from what I understand, tumors exposed to treatment can mutate, and I've got a lot of friends that have mutated from no driver mutations to ALK, non-small cell to small cell. So I always try to get one every time I have progression.
That's an important thing, Dr. Kelly, if you want to kind of talk on about rebiopsying, when to retest.
Yeah, so I do think that, and I also tell the patients this all the time too, is that if your tumor progresses, we absolutely need to retest, all right? We try to do the liquid biopsy first, you know, when we know what we're looking for, but we also recommend a tissue if the liquid biopsy isn't going to give us the answer. So yes, and of course the explanation is the same, is that we still want to do precision treatment, you know, for you. It sounds like you've had lots of those, but nothing's panned out.
Yeah, so my issue is the drugs have worked awesome
Except for,
in my body.
yeah, except for up
and
here.
not particularly well in the brain.
Right.
And they're in places where it just makes absolutely no sense to do a brain biopsy.
Absolutely, yes.
So that's really off the table. So we've tried blood biopsies twice, even with pretty large volumes, so they could try to spin something down, and that was useless. And then they even did a trial on trying to spin down spinal fluid. I went in and got like I think it was a 20 cc tap, which is actually a lot of fluid. And again, the initial testing was really not much there. Then it went out to testing at a special lab, and they spun it down and whatever, and couldn't get enough data. And because cancers, from a layperson's point of view, start at relatively simple, and then as you're throwing different treatments at it, they keep getting more and more complex. The data from the very beginning, when back in 14, I think they did a FISH test or something. It wasn't even that sophisticated because it was 5 years ago. They found out I was ALK, but since then, since this is all stable, they've got nothing to go on.
Right.
And clearly it's mutated, but we don't know in what direction.
Yeah, you do have a unique situation. I mean, but we still do have, lorlatinib is still out.
That's the next
Which
one.
does
I'm on Brigatinib now.
I know. So there's lorlatinib, and there'll be more to come.
And that does cross the blood-brain barrier.
And it does cross, and though I can see that is you're very unique, as you already know, and that's very frustrating. But the good news is that we still do have drugs. And I'm sorry, have you had chemotherapy at any point?
I have not, and that is on the table. And we also, from the very beginning, I have a pretty positive attitude anyway, but I've always had the attitude of, well, all I need this drug to do is work long enough to get to the next best thing.
Yeah.
And then I need that one to work long enough to get to the next best thing, and so on. And the drugs have actually been coming to the table faster than I've been going through them. So I'd say, doing pretty good.
Yeah, I think, but just as a backup, just as that backup plan, the good news is that pemetrexate does cross that blood-brain barrier. So that is good. So just as a backup, plan C or D.
I want to pause really quick and check in with Amy and Michelle to see if there's any online questions before.
I think you handled most of them. I was just responding to one kind of in real time regarding a patient who is this PD-L1 50%, but EGFR negative, ALK negative, KRAS negative. So the question is, it sounds like kind of these sequential tests almost, and I'm kind of reading into what she's saying, but what would your recommendation be? Further testing to rule out the other kind of approved targets, or given a PD-L1 of 50%, do you kind of go on those negative results and move to IO?
So I'm sorry, did you say she was squamous? What did you say? She's
stage 3A non-small cell.
Yeah, so I would go ahead and get the remainder of the test because, again, you'll find a HER2. You will find some of these others.
Exon 20.
Exon 20s, NTRK, you will find them. So adenocarcinomas really should have that comprehensive testing. Then if she doesn't have anything, then you can move with the immunotherapy.
I'm glad I was saying the same thing you just said.
So Bonnie, I do want to go back to the question that you were raising about with the commercials about the immunotherapy. You're right. Patients come in, my EGFR patients, they come in and say, I want to switch to this. I want to switch to that. And so, I have to explain to them that that's not the right therapy for you right now. And that it is true, and this has already been said, that patients who have these actionable mutations like EGFR and ALK don't really honestly do well with these drugs by themselves, I would say, FYI, even when you have that high percentage. So if you're gonna do immunotherapy, I would combine it with something. So one of the regimens that's out there that I have actually had good luck with has been the regimen. It's called the quad now. I know that sounds, it's 4 drugs. It's the chemo plus the bevacizumab plus the atezolizumab or pembro or whichever one you want to do there. But the trial looked at Taxol, Carbo, Bev, and atezolizumab. And, I personally like that regimen myself in patients who are EGFR mutated. I have a patient, I have a patient, and just like you guys, the second the scan comes up, I'm looking because I know when my scans are coming up. And so I looked at my patient who I'm going to see tomorrow, and I already looked at his scans, and he's had a really great response to that quad. Now I have to dose modify the chemotherapy. Again, I do a little modification for my patients. And he's not my first patient who has had really good responses. Now again, this is my own personal experience. So for me, if you have a mutation and you want an immunotherapy, I would do it in combination with the quad regimen or some.
And we're going to make sure that Barb hears exactly that same thing.
Oh, yeah.
And the dosing is really, really important because years ago they didn't do that, and they put men and women on the exact same dose, and it's like, even I know that's stupid.
Well,
we're smaller, we need less toxicity, it's crazy.
Yeah.
And, dosing is
And again, remember, there's not one set dose in chemotherapy. There's always an efficacious dose range.
Right.
So particularly when I'm giving the quad, the patients that I've treated, I have dose reduced the chemo piece.
Yeah.
Because of, I am concerned about toxicity and making sure that they can handle it.
Yeah.
So my point being is that the immunotherapy, I think it is in everybody's armamentarium at some point, even the mutation patients, but I would not do it by itself, even when you have a high PD-L1.
Right.
That's my.
So one of the things we're believe it or not, getting not super, well, we have 15 minutes left.
Okay.
Yeah.
But one of the things I really, really want to touch on, because I think it's important and there's a lot of promise being shown and it's going to be really impactful for a lot of people, is some of the evolving therapies happening, particularly in KRAS and then in RET. So if you could talk a little bit about that.
So I think, this year at ASCO, which is our national meeting, in previous years, it's always been about immunotherapy, but this year it was really about the targeted therapies and about all the exciting things. Again, newer drugs for MET, newer drugs for ROS1, repotrectinib. I love that name. It just sounds like it's going to kill tumor cells.
Like
don't you
dinosaur.
Don't you think? It just sounds like it's just going to kill the tumor cells. I think every drug should have that name that sounds like it's going to kill a tumor cell. The RET drugs, Blue and Loxo, but the most exciting data that was presented, not even in the lung cancer session, of course, in the session going on at the same time, so none of us could even go to it, was the Amgen drug for KRAS G12C. It's an oral drug, it's a TKI, and the trial was the very first trial. It's called these first in human studies. And so it had patients who had G12C, but colon cancer has that as well, and there are other tumors.
And skin.
And, yeah, and there are other tumors that have that. So nonetheless, there were 10 patients. These 10 patients has created a storm. 10 patients, and 5 of them had dramatic responses to this KRAS drug. It's huge. And so now there is just excitement around the world. KRAS is the most common driver mutation in
30%.
adenocarcinoma. So this is huge. And so again, everybody is wanting to get that drug at their institution in a clinical trial. So, and
we had the CEO in our office last week.
Oh, great.
On
great.
Amgen.
Yeah, Amgen. Yeah. So, right. So more to come on that story. But this is, again, the power of technology and drug development, understanding how to look at these biological pathways and be able to learn how to get into these pockets, these enzyme pockets.
And how important clinical trials are.
Yes.
Maybe you could say a little bit about that, because sometimes people are afraid to go into a clinical trial.
Yes. Really, again, we encourage every patient to go into a clinical trial, because that's how we can get these drugs the fastest to everybody. All right, so it is really important to help us, help everybody, help you too, by participating in these clinical trials. The reasons why, again, we learn so quickly about these targeted therapies is because patients did quickly go on. I will say that drugs like the KRAS drug, and we have a big phase 1 program at UC Davis as well as Stanford and UCSF, but if those trials open, I would suspect in 1 week they'll be closed, because every patient's going to want to go on that drug. But that should be true of any of our targeted drugs, not just KRAS. So when we have a great drug like the blue drug or the Loxo drug or the MET drugs, again, the faster we can get patients on and get the responses, the faster we get it to all patients. All right. So,
and the FDA is working at monumental speed these days.
And they are recognizing that. And that's because, again, you as patients are demanding that. I think truly the FDA has heard your voices and has, your voices, and said, not acceptable. We got to move forward.
10 years.
But again, if you're going to say that, you've got to be willing to participate in the clinical trials too. So, it really, we need it all.
Yeah, and we try to drive that home at almost every living room.
Yeah.
Somehow clinical trials comes back into the conversation, because, as you have all heard me say ad nauseum, and folks watching online, it is so important in order to get these things fast-tracked, because it is an exciting time right now.
It is an exciting time. And so, that is so true. And we're all working together to do that.
So on clinical trials, in this whole journey, the 2.5 years that I was first time in humans on X396, it was by far the best
That's what you
quality of life of the entire
What is
journey.
X396?
X396, I think it's called Encertinib. It's not approved yet.
Yeah.
It's still in trials. But I was in the first study of 100 people. I was like patient 60 or something. There's a few other people in our ALK group that are still on it. So it's still going through trials. I think they're in like third phase now.
Yeah.
But it was a great drug, and really it is good for people to do trials.
Yes, and so we do encourage. Remember, as a patient, I just want to remind you, key messaging here is that your doctor really should always be giving you the clinical standard of care option and the clinical trial option. You should be getting both. Or if they say to you, here's a clinical, the standard of care, they should at least say, I don't have a clinical trial for you at my institution. They should at least say that and say, but you could look other places. Now, one of the things that we do at UC Davis, and because we are fortunate to really be in logistically placed with UCSF and Stanford, and we know each other so well, in the middle of clinic, we're calling, hey, Joe, Dr. Neal, hey, Matt, hey, Heather, hey, I've got this patient. We don't have the trial here. You guys have it. So I have patients at both places because maybe we don't have that trial, and they have patients at our side because we have the trial. So it works both ways, and that is really beautiful because we know each other so well, and we will give the patients the UCSF option and the Stanford option and see what they have.
Yeah,
we talk to them all the time.
Yeah, and I think, and some of you know this because we've talked about it before, a program that UC Davis has put up with some community hospitals, spreading out pretty far and wide around doing what's called a virtual tumor board. Or they used to be called tumor boards, they changed it, I don't know. But where the academic docs get to talk with the community docs, and they get to kind of share those cases back and forth and really get to come to a unified, informed decision about the patient population, which is a huge, huge thing, and I'd love to have another conversation living room around that and how to make it work, especially for places like Montana.
We are fortunate right here in Northern California because we do have powerhouses on the research side in lung cancer.
We do. If you have to have cancer, this is the place to have it.
Fortunate about that.
I was just going to say, you made a really important point, because actually I'm going to try to set up a appointment with Dr. Gandera next week for a clinical trial. And I didn't know that you guys worked with UCSF and Stanford. And, I know Dr. Neal and Heather. So that's great to know that. And I'm on Medicare. I'm with Kaiser. And my oncologist told me, if you're on Medicare, you can go anywhere you want for a clinical trial. So
I would say we work with Kaiser. Again, I think some of these are misnomers. We have many Kaiser patients on our clinical trials, particularly in the phase 1 type of setting. So what we do is all the research studies are done at UC Davis, but your scans, the blood work, it's all done at Kaiser. So it is a win-win. You work together, we talk to your doctor, we collaborate where we can, we get the approvals. So we work really hard to collaborate, and that's actually gone well, I would say. So we don't have any problems working with Kaiser, actually, or Sutter, or Mercy, or any of the groups. We don't have a problem with doing that, and we're happy to do those things.
Which is huge.
Yeah.
Tony, do you have a question?
Oh, I just wanted to make a comment that if you don't have that type of relationship with your oncologist, or if they're not that type of person, or if you're in a outlying place, that I learned about a clinical trial available to me by calling the Go-To Foundation, and Melanie put me in touch with a champ who is back east in Washington, D.C., and we sat down and we talked through what would be my next, course of action. We decided that probably a clinical trial at this time would not be good, and that I should go on brigatinib. But just in case you're someplace and you don't feel like you can get that help, call Go-To, because they are the place to go to.
That was a shameless plug, and I didn't have to give it. So the ALK Master Protocol has opened. So, and it's got a ton of different arms on it. But there's also a trial at UCSF and now open at UC Davis as well. So FYI about that too. There is one trial that's open. It's a combo study. So Joel and Jonathan are running that study.
So I hate to stop this robust conversation. But we are about 4 minutes left in tonight, and I have a couple of housekeeping things that I want to go over. Hopefully over dessert, Dr. Kelly will be able to stay for a little bit and answer maybe a couple of questions before she has to get in the car and get back to Davis, Sacramento area. So some upcoming events next before we get into the events, I want to talk about some of the next living rooms. Next week in Washington, D.C., Michelle and I will be out with Dr. Levy from Johns Hopkins.
Ben Levy, amazing.
Yeah. Is that what I said?
You said Levy, I said Ben.
Oh, doctor, I said Dr. Levy. Dr. Benjamin, if we're getting very technical and appropriate about it.
He's great.
He's great. He's done a living room out here before locally, but we'll be in D.C. It will be live streamed, same time, only East Coast. So any of you who want to join in and listen to what's going on there, the topic is navigating the journey of lung cancer from treatment to diagnosis and beyond. He will also have his thoracic cancer nurse navigator, Candace Graham-Adderton, and the medical oncologist nurse practitioner. That's Candace, sorry, the nurse navigator. Nope, sorry. Nurse practitioner is Rashida Persinger-Adams. I'm trying to read quickly and backwards. Anyway, that's August 29th, next week. September 17th, we'll be back here in this office with Dr. Neil from Stanford. We've talked a lot about him. We're going to have an entire meeting around immunotherapy. So even if you're on a targeted therapy and it's working perfect, we expect to see each and every one of you in your seats so you can go back and spread the word about what you learned to other people that you may come across during this journey. September 19th, we will be in Toronto, Canada, at Princess Margaret Cancer Center with Dr. Francis Shepard and also Dr. Natasha, I'm going to mess up this name. Lale, yes, whom I haven't met. I do know Dr. Shepard, but I have not yet met Dr. Lale. So I'm very excited to meet with them. And they're going to be talking about New Hope in Lung Cancer research. So they're going to kind of step back a little bit and talk a little bit more about what's coming down the pike. So we're really, really excited about that. And then next month, I'll talk to you about October, and Michelle and I are going to be down at the International Association for the Study of Lung Cancer, the South America meeting. We're going to be doing a living room all in Spanish from the meeting down in Mexico City, which should be
Danielle
pretty
took a
interesting.
crash course.
Yes, no, Danielle did not.
Let's hear your Spanish.
Danielle is relying heavily on Dr. Reyes and some of his buddies down there in South America. So that'll be really exciting. But I want to introduce you guys to Bridget, and I don't want to put her on the spot, but if I could get her a mic, because this is her first living room. She's been with our team for a little bit now, and she's going to give you a little bit of, somebody grab her mic, Dawn. You're somebody. Thank you.
Thank you. Hello, everyone. I'm so thrilled to be here. This has just been a wonderful night tonight. Thank you all for sharing your stories and for being here. I'm really excited to share that our largest run walk that the GoTo Foundation has is coming up September 22nd at Lake Merced here in San Francisco. And then we have 3 more coming up for the rest of the year. October 6th in Philadelphia at the Philadelphia Zoo. So anyone on the East Coast, that's our one coming up there. And then we have 2 more coming up, Houston, Texas, and Hollywood, Florida on November 2nd. So we hope you'll be able to come out to those events. And then I'm excited for my colleague Susan here to tell you about our upcoming marathon events we have coming up.
Hi, Susan.
Sure, thanks. As Jason mentioned in his introduction, he's one of our 16 runners that have fundraised to have a place in the New York City Marathon. And so we'll be out there November 2nd. So if you're in the New York area, please come out and cheer on our runners who are fundraising. And, you know, I think you certainly mentioned really well that you're living from treatment to treatment, right? And those treatments and those breakthroughs come through only because we're funding them as a community. And we're also advocating to get a bigger piece of the pie from federal funds as well. Well, those programs do take funding as well as clinical trial, concierge, et cetera. So in addition to that marathon. We also, if a full marathon isn't your jam, we have a 10K and a half marathon in wine country coming up in October. And we also have the Air Force marathon and half marathon happening on the East Coast next month. So, and if none of that is of interest to you, just like Don did, you can turn anything that you love to do into a fundraiser, any celebration into a fundraiser, and we can help you do that. We certainly had one for an anniversary, for weddings, et cetera. So let us know how we can help you continue these programs.
And Susan, this isn't your first living room.
No, this is my second.
Did you introduce yourself last time? Do you want to?
I did, but I'm a 21-year lung cancer survivor as well. I was diagnosed when I was 32 and a brand new mom. Certainly was not expecting it, just like all of you in the room. So it's thrilling to still be a part of this community, but particularly in the last couple of years to see the advances that have happened. And it's been because of this spirit of asking for more, demanding more, wanting more, and coming together to ensure that there's more. And it's exciting to be a part of this joint community now and really see the advances multiplying. So it's really exciting.
Thanks, Susan. One last thing I want to talk about. Some of you know Francis Spruitt and his lovely, lovely Rosalind. They come to this meeting quite often. They are hosting a Wine Hard, Breathe Easy event on Saturday, September 28th. Yeah, Bonnie's got her hand up. At their home out in Hercules. So anyone who's interested in participating in that event, it is a wine tasting event, obviously. They are asking for a $20 donation. Of course, it's not mandatory, but they're asking for it because they are trying to raise funds that will go right back out the door to help fund research and patient services and programs. But Wine Hard, Breathe Easy. If anybody is interested, please reach out to me, and I will give you the information on that. And then the second thing the last thing I want to bring up before I thank everybody is an event that's happening. Some of you know about the meeting that's happening in New York City, and it's the annual New York Lung Cancer Symposium. One of the things that's unique about it and why I want to point it out this year is because I think it's important to some of you in the room and some of you watching, maybe particularly from the greater New York area, is that they've added a patient track this year. And when I first heard about it, I was like, oh, it's like the last hour on the last
Of
day.
course, yeah,
Nobody's
they're
going to
gonna
come.
come.
But it's literally an entire day, and the agenda looks amazing. So anyone who is interested as a patient or caregiver in going to that, I have the information for you. Cure is sponsoring it. And not like I mean, we love Cure. We have a great relationship and partnership with them. But I'm really excited about this day, so I wanted to make sure to share it with you.
When is it?
November 9th.
Yeah, I'll be there. I'll be there.
Yeah, it's that weekend. It's the same as our gala, so those of you in the room might not be able to
it's the same as your gala?
make it.
Go on our gala.
Some of our East Coast colleagues are going to be up there, so there will be representation from GoTo at the meeting. But I just thought it was important because I really was excited about the patient track, thinking, oh, they're actually put a lot of thought into this, so it's great. Huge thank yous. We're going to come to the thank yous, and then we're going to eat cake and finish our wine. Sally, thank you for cake, always.
Yeah.
I saw that you put a big go-to shout out on the top of the cake, so I really, 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 really thank you for that. Obviously, first and foremost, thank you to patients and caregivers, everyone in the room, everyone watching live tonight, everyone who comes back and watches the recorded post-live sessions. Again, I'll say it, you are why we do this. Thank you for continuing to come back and supporting us in supporting you. It's what you, tonight is why we do what we do, right? Tonight is why we do what we do. Thank you, obviously, to Dr. Karen Kelly for coming out.
Thank you guys.
And having what I really feel like was a very personal, connective, easy to understand conversation around biomarker testing and why it's so important. So huge, huge thank you to her. Obviously, Peninsula Television, the crew that comes in here every month, sets up the station, the film crew in the backyard. You look up here, you see it all. That's what's all set up in the back room. A huge thank you to Penn TV for coming out. For those of you that do live locally, Channel 26, this meeting, just like every other meeting, will replay over and over and over until we record this again next month and the new one comes up. So as Bonnie says, when you are awake at 2 o'clock in the morning and you have nothing else to do,
you can see us on TV.
Rewatch this meeting and watch yourself on TV. Thank you to the Office Bar and Grill once again for bringing in the food. Thank you to Kim Shapoister. I don't know where she is.
Cleaning the kitchen, I hope.
getting the food all set up, getting the room set up, making sure you all have wine, which is one of the most important things. Huge thank you and shout out to Kim. And then last but most definitely not least, and this I need my glasses to read from the list, is the people who support this so that we can actually bring this to you every month. So a huge thank you to AbbVie, Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Dignity Health, Foundation Medicine, Genentech, Lilly, Medtronic, Merck, Novartis, Takeda, and Tesaro. They all believe in this because they all believe in you. So a huge thank you to all of them. And with that, let's go have cake.
Yeah. Let's eat cake.
Oh, you want to add
one more thing.
Thank you to all of the researchers.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.